Hi, Vineet. Hi, Savarna.
Hi, sir. Hi.
Hi.
Hello,
Good
Vineet.
afternoon, everyone.
Hi, Nitya.
Hi, sir. Good afternoon, sir.
Good afternoon.
Good afternoon, Vineet, sir.
Hi, good afternoon.
Good afternoon, everyone.
Good afternoon, Dr. Nirmal.
Hi, afternoon, everybody. How are you, Vineet?
Fine, thank you, sir.
Good afternoon, everyone.
Good afternoon.
Good afternoon, Surinder. We should wait a couple of minutes more, 3-5, we will start. People
Yeah.
are joining in. You have a YouTube link, Nitya?
Yes, I'm sharing.
I would request all of you to please send the link to all of your friends.
Yeah, I shared with our ALS support group of 450 members. I don't know how many will join, but yes, that's I've shared. And also on the social media.
Thank you.
Can you start, sir, now?
Yes, please. Go ahead.
All right. So very warm good afternoon to all of you all, and thank you for gracing this occasion that is organized by the Neuro Rehab subsection of the Indian Academy of Neurology and the Indian Federation of Neuro Rehabilitation. We celebrated worldwide as the World Motor Neuron Disease Day. And for the year 2025, every day is the longest day, is the theme that has challenges faced by unpaid carers of people living with motor neuron disease. The day aims to raise awareness about the dedication and lack of financial support experienced by these caregivers who dedicate over 100 hours a week to providing care in Neuron Disease Association. And to lineup of panelists who are available over here. And I would like to ask Asmita to just share the CV slides of our panelists today. It gives me immense pleasure to introduce our chairpersons for the session today. The first and foremost being Dr. Nirmal Surya, who is a father figure in the field of neurorehabilitation and neurology in India, but also in the world. He is a honorary neurologist at Bombay Hospital and Medical Research Center and at Saifi Hospital and at North Court Police Hospital, Nagpada, Mumbai. He is the president of the Indian Federation of Rehab, Secretary General of the World Federation of Rehab, the president of the Asian Oceanian Congress on Neuro Rehab, and the list just keeps going on and on. And I can proudly say that I am mentee to Dr. Surya at the World Federation of Neuro Rehab mentorship program. We welcome, sir. Thank you for gracing this.
Thank you.
Second chairperson for today is Dr. Abhishek Srivastava. He is the director. He's a neurorehabilitation specialist and the director at the Center for Rehabilitation at Kokilaben Dhirubhai Ambani Hospital in Mumbai. He is the director of the Indian Federation of Rehab, and he's the chair of the Rehab subsection of the Indian Academy of Neurology. Sir is a member at large at the Presidium of the World Federation of Neuro Rehab. He's the chair of the Special Interest Group of the Multiple Sclerosis at the World Federation of Neuro Rehab. He's the chair of the Education Committee of Asian Oceanian Society for Neuro Rehab. And he's edited a lot of books and has done a lot of research. And we are very happy to have Sir with us today as a chairperson. Welcome, Dr. Abhishek. And I'm going to be the moderator for today. I'm an assistant professor at the Early Intervention Center at the Topiwala National Medical College and BYL-Nair Charitable Hospital in Mumbai. I'm a neurophysiotherapist by profession. And coming to who are there, the first and foremost, we have Dr. Vineet Jason, who is a neurologist. He's the professor and lead consultant at the Neuromuscular Center of Excellence, Department of Neurology at the Christian Medical College and Hospital in Ludhiana. He specializes in the area of neuromuscular disorders, and he was one of the organizing committee members for the recently concluded IAN-IFNR conference that was held at CMC Ludhiana. We welcome you, Dr. Vineet. Coming to the next, Dr. Navita Purohit, madam. She's a consultant psychiatrist and specialist pain medicine and palliative care specialist at the Kokilaben Dhirubhai Ambani Hospital, Mumbai. She specializes in ultrasound-guided pain management, regenerative medicine, and placement-rich plasma therapy. She's the honorary secretary of the Indian Association of PMR, that is Physical Medicine and Rehabilitation. She's the program head for the fellowship of the Indian Academy of Physical Medicine. The first woman in India certified interventional pain sonologist from the World Institute of Pain. Madam has been working considerably in the field of palliative care recently, and she will be joining us shortly. And we have a few questions for her as well. And coming to the next panelist, we have Dr. Sumit Singhania, who is a consultant pulmonologist at Kokilaben Dhirubhai Ambani Hospital for the last 8 years. He was a previous consultant in respiratory medicine in Manchester, UK. He specializes in non-invasive ventilation, asthma, and in ILD. He holds a postgraduate certification in medical education from Edge Hill University, Liverpool, and medical leadership diploma from Manchester Business School. We welcome Dr. Sumit Singhania for this webinar today. Our next panelist is Dr. Suvarna Ganvir, who is a PhD and professor and head of Department of Neurophysiotherapy at the Dr. Vittalrao V.K. Patil Foundation's College of Physiotherapy at Ahmednagar. She has 23 years of teaching experience. She's a recognized PG and PhD guide of MUHS Nasik, and she is a CMCL Famer Fellow, and she's a member of Board of Studies at the Allied Health Science of MGM University. She's an associate editor of the Journal of the Indian Association of Physiotherapists, and she's the coordinator for the Maharashtra State IAP Women's Cell and EC member of IAP Maharashtra State Branch. We welcome you, Dr. Suvarna Ganvir, ma'am. Coming to the next is Dr. Srinitya Ji. She's a master in occupational therapy. She is head and superintendent of occupational therapy since the last 20 years in Nimans. And she has been working in the field of neurology as pediatrics. And we welcome Dr. Srinitya madam for this webinar. And then we have a speech pathologist, speech and language pathologist, Dr. Preeti Shetty. She's also a PhD. She's an assistant professor presently at the Department of Audiology and Speech Language Pathology at Kasturba Medical College, Mangalore. She is a treasurer and founding member of the Society for Feeding and Swallowing Disorders, India. She's the Dysphagia Core Group Council member of the Indian Association of Parenteral and Enteral Nutrition. She's a member of speech language, pathology, and audiology. We welcome Dr. Preeti Shetty to the webinar. We have Mr. Lukesh Kumar Bhuayar also. He's done his bachelor's and master's in prosthetics and orthotics from the All India Institute of Physical Medicine and Rehabilitation, Mumbai. He is a lecturer at the All India Institute of Physical Medicine and Rehabilitation. And he is an orthotic, and he has a professional membership of the OPAI, the STAMI, ICAP, RCI, and IAE, where he is the joint secretary as well. We welcome Mr. Lukesh Kumar Bhuyar to the webinar, please. And last but not the least, we have Ms. Satwinder Kaur as a co-founder and director for the ALS Care and Support Foundation. And as the theme for this year is the longest day is each day, and this is recognizing the work that our caregivers have been doing for all our individuals with ALS. And it's very important to have Ms. Satwinder Kaur over here because she's formed this. And I extend a heartfelt welcome to her for this webinar. So without much ado, we will request Nirmal to share a few words and followed by Dr. Srivastava.
My first instruction is that the introduction to everybody should be in 2 lines. We have very limited time, and we cannot waste 15 minutes in introduction of all people, they can be introduced. Good afternoon, everybody. It's great honor for me to be here today. Today is the 21st June, and I don't know why this day is important when Hitav has already told you that this is the longest day. But look at this. Today, Mr. Modi, our Prime Minister, has made it as an International Yoga Day. ALS has been celebrating it as a ALS Day. And not only that, today is also the World Music Day. So I believe that longest day of the year has got a very important direction probably for people to choose it, and to have music and yoga to the calmest part of the, our day-to-day life, to make us cool and calm, to collaborate with its ALS is something which is very, very important. You all know about a disease which I don't feel good when I diagnose the case, and I'm sure Vineet is going to tell you all in more detail about the disease. But every 90 minutes there's one case diagnosed in USA, and every 90 minutes one person dies because of ALS, and that is the serious thing, because at the moment we do not have treatment. But when you don't have treatment, what best you can do? This is what the Indian Federation of Neuro Rehab and the Neuro Rehab subsection planned it out, that when there are no treatment, how best we can help the people who are suffering from a disease, neurodegenerative disease, which has got no treatment. So I'm sure those people who really have their relative friends, Satwinder Kaur is here, and she knows how much painful it is. To reduce their pain, how best all this team, multidisciplinary team, can do, which is different from what new treatment are available. And I hand it over to Abhishek to say a few words before the moderator, Hita, who is a very young, dynamic physiotherapist, to take the questions. I think everybody will have to answer briefly so that maximum questions can be covered and maximum information can be given to those, because about this disease nobody is talking. There are no much awareness about this disease. Yesterday only I saw a patient which clearly from the history I could diagnose is that there's a ALS, but going for last 6 months from neurologist to physician, from orthopedics to everywhere, everything has been done, including the EMG, but including the nerve conduction, but not the EMG, and therefore they miss the diagnosis. So I think we will like to learn few tips from you all guys, and how best early diagnosis, early intervention, and how we can guide these people. Please go ahead. Hita, over to you after Abhishek.
Thank you, sir. I think a lot of focus is on stroke and TBI, but we forget the neurodegenerative disorders Parkinson's, ALS, MND, they are also equally in numbers, and they also cause significant disability to both the family and the caregivers. Wasting any time, on behalf of the subsection of IAN and IFNR, to welcome all the panelists. Krijita, please take over the panel discussion. Thank you very much.
Yes, sir. So now my first question, there'll be a few round of questions that we'll be going around. So my first question would be to Dr. Vineet Jason. Sir, what are the early signs and symptoms of ALS or any motor neuron disease that the public or any healthcare professional should be aware of, sir?
So motor neuron disease, we do understand, is a disease affecting the anterior horn cells and also the corticospinal tracts. So because of that, what happens is that anterior horn cells supply the motor neurons. So everything that requires voluntary action. So the voluntary action that is required for movement of hands, of the shoulders, legs, abdominal trunk muscles, breathing muscles, bulbar muscles, any of these things can be affected. And ALS onset is very insidious, so it begins very slowly. So you can begin with very mild, if it is affecting the bulbar areas, it may be just mild slurring of speech, mild dysarthria. So at that time, it should not be missed, or they may have some difficulty in swallowing. Usually it begins with the limbs. So most often they will come with weakness in the hands, or they may have some difficulty which may be in the shoulders or in the feet. Very often they are mistaken to be radiculopathies of pain. So these are some findings that should not be missed. Also, one important thing is cognition. This is something very hard to diagnose in patients who do not have other features, but we know that FTD coexists is there with ALS, especially in certain genetic mutations. So they can come with behavioral changes. That's also one thing that is possible. Very difficult to diagnose at that stage, but something to be aware of.
Thank you, sir. So, as sir said, that an early sign are what we have to look at, and early intervention and early diagnosis is very important. So, coming to the chest physician, the pulmonologist, Dr. Sumit. Sir, what are the issues that we discuss right now? Challenge in ALS, as we all know. When should families be alert to breathing difficulties, or when should they come to a pulmonologist, sir? Or when should a patient be referred to you?
Right. So I'll answer the first part, which is the respiratory involvement in motor neuron disease. The families should be looking out for respiratory symptoms, which include shortness of breath, inability to complete a sentence in full, in a single breath, shallow breathing pattern, or poor cough effort. Now, again, these patients can have a raised carbon dioxide level in their body, which manifest as early morning headaches or daytime excessive sleepiness. And finally, the respiratory muscle weakness goes hand in hand with the weakness of the speech and swallow. So if they have a weakness or they have change in their speech and they're finding it difficult to eat or choking on the food, then there is a good chance that there will be an associated respiratory muscle weakness as well. In terms of when they should be coming to a chest physician, once they've been diagnosed, I think they should be referred early, because different patient will have a different timeline in terms of involvement of the respiratory muscle. And we don't necessarily wait for the symptoms to appear before we start thinking about treating the respiratory muscle weakness. So we tend to monitor them regularly with lung function testing. And once they have a baseline lung function test, we can then decide how often to see them so that we can pick the weakness in the respiratory muscles early.
Thank you so much, sir. Now, moving to our next question, the next panelist, Dr. Suvarna Garveen, madam. What is the role of physiotherapy in ALS, especially when the mobility starts declining?
Thank you, Dr. Hitar. And thank you, IFNR, for having this particular panel discussion on very important topic of ALS. As far as physiotherapy is concerned, The most important aspect of physiotherapy is about maintaining the mobility and flexibility in these patients rather than trying to build up the muscles. So the most important aim that a physiotherapist should have when treating with these patients is that they should try and maintain the mobility by giving simple stretching exercises or simple gentle exercises rather than trying to be very vigorous with these patients. So especially when the ambulation is starting to decline and when the patient starts becoming sort of not bedridden but restricting to one particular place. So that is the most important thing.
Okay, thank you so much, ma'am. Coming to our next panelist, who's an occupational therapist, Dr. Srinitya. Uh, how can occupational therapy help ALS patients remain independent in daily activities?
Thank you for shooting that question to me, Hita. So, see, as an occupational therapist, our focus is on a holistic approach. We find out what the limitations of the clients are so that we will focus on their limitations and help them do what they wanted to actually do. In that way, we focus more on the functional aspect capacity of the patient to find out what their motor skills are. Are they able to do the activities with their hand functions? Is it enough that they can do their work by themselves independently, or the cognitive function, as Dr. Vineet has mentioned. So these are all something very important that we have to do the assessment. Along with that, we also focus on energy conservation techniques, like you have to teach them to how to plan the activity, prioritize the activity, pace and position their activities so that they are independent throughout the day without overburdening the caregivers. Then we focus on the task modification. I'm talking about task and work simplification in the no, third phase, because we want them to be as independent as possible as long as they have the remaining functions with them. So when they're not able to do the functions more than what their capacity is, and then we would focus on their modification and work simplification, where we will be helping them to improve their quality of life. And finally, getting back to the transition phase, after the disability has come, and then they know this much is the thing that they can do. How is the transition going to happen? And progressive planning for the patient is what, as an occupational therapist, usually we focus on.
Thank you so much, ma'am, for that very interesting way of how an occupational therapist helps an ALS patient. Coming to a speech and swallow therapist, Dr. Preeti Shetty. Ma'am, how does ALS affect speech and swallowing? And when should one seek help of a speech and language therapist?
Thank you, Hita, for that question. I would like to highlight that ALS doesn't take away speech and swallow deficit, or it doesn't take away the speech and swallow overnight. It's going to be a slow change. So I'd like to highlight how it changes through early stage, middle stage, and advanced stage. If you look at early stage, you're going to see a slurred speech, or you might be looking at mumbled speech whenever they are tired. So if you see swallowing, they may cough occasionally, or they may have swallowing difficulties whenever they are tired. So if you see middle stage, if you see the speech becomes, or the words become harder to understand, and also they may use few words to speak, or they may avoid situation. So if you see swallowing, they may prefer mixed textures. They may not use the regular food that is used priorly. So if you see the advanced stages, they may no longer speak, or swallowing becomes more difficult, and they may be tube dependent. So if you ask me the question, when do they seek help? It's important to seek help at the early stage, because it's going to make a difference, and it may help in protecting the quality of life of the patient.
Yes, sir. So now the next question is to Mr. Lukesh, who's an orthotic on the panel. What type of orthotic devices are useful in ALS, and at what stage would you like to intervene as an orthotic in ALS patients?
Yeah, thanks, Dr. Hita. So, going stage by stage, if it is an early stage intervention, We usually go for the for lower extremity ankle foot orthosis, which should be light in weight, and for the upper extremity wrist hand orthosis WHO. The purpose is to have the mobilization as Suela ma'am said, the mobilization is needed, and these orthosis should be lighter in weight so that the person will easily don and doff, will put it on and take it out. The caregivers will help them to put it on and take it out. At middle stage, there can be a knee ankle foot orthosis and then other orthotic intervention depending on the involvement. And in later stage, if there is a contracture or so, if the patient is going for the contracture or so to prevent that contracture, there are positioning devices so that can be fitted to the patient, and with that we can prevent the contracture. So basically, it is a supportive care from orthosis that will help the patient to do the activities of daily living and help him and support him by orthotic intervention.
Thank you so much, sir, for your crisp introduction to what orthotic is and how the orthotic devices should be for our patients. Coming to Ms. Satwinder Kaur, who's a social worker who's been working in this field of ALS and motor neuron disease. What are the emotional and social challenges that are faced by ALS patients and their caregivers?
First of all, knowing that kind of disease which is incurable, and you have been told by the doctor during the diagnosis that you'll be losing the ability to walk, speech, and swallowing, and also later on in the breathing part also. And there is no treatment available. It really, every family go in a shock stage and in a traumatic experience. And that is really emotionally turmoil for the family. And then later on, when they see there is no direction available, because of the less awareness, and even in the medical fraternity as well, I think the guidance is not available. So they without the direction, they lose the sight that what needs to be done at what time. So that creates a lot of stress with the family, that what I need to do, where I need to go, and when I need to act on what stages. And also understanding that you require a 24/7 care, and the person would be losing an ability to walk. And if the person is a bread earning member of the family, that patient, or maybe the primary caregiver, that financial aspect also takes that toll, that how they will take care of the burden of the financial things upcoming, because you require different kind of assisted devices, you require cough assist, BiPAP machines, and all those things. So you need to be well prepared before opting for all these things. So that financial, the job security, everything emotionally and I would say socially, they usually cut out from their relatives, friends, because nobody understand what they are going through, and the complexities of the disease, what family is having. People say, okay, there's some, you go to this VAS or anything like that, because everyone has their own way of interpreting that kind of treatment for something which is incurable. So that creates a lot of stress with the family, and they literally, I have seen in my case, and over 700 patients which I have connected with through ALS care. So that social disconnect happened, but that's how we connect them together as a family in this support group. So everyone can talk with each other and then take a cue what needs to do next. Thank you.
Thank you, Ms. Satwinder Kaur. So that ends our first round of questioning with all our analysts over here. And I would just like to sum it up that it is an early intervention, an early diagnosis, an intervention, and an early referral multidisciplinary members. That is the takeaway message from this thing. And now, since we are talking about the caregivers, as the theme is the longest day is every day. So let us start with our second round of questions, which will be focusing only on the caregiver aspects of ALS and MND. So my first question is Dr. Vineet Jason. Sir, what do you think, or what are things that a neurologist or a first care practitioner who breaks the news to the relative as well as the patient should take into consideration while breaking this news to them?
Thank you, Hita. That's a very, very important question. Um, uh, as neurologists, often we are not very well trained in palliative care. I mean, this is a very how do I put it? Something that you learn along the way, but more and more it should be included in the curriculum. But taking from palliative care, how you break the news, a news that is life-altering news, to say that somebody's life is no longer going to be the way it was, and their life is going to be shortened. There are very clear guidelines on how to break that news. I mean, there's a whole list of it. I won't go the spikes models, various models to do it. Basically, to say that it is well understood in the palliative world, but not so well understood in neurology. But I'm sure with so much of effort that's being put even through this webinar, more people will be aware. Essentially, we need to have a private space, first of all. We don't need to be in a hurry. We should give the patient enough time. We must ask the patient whether they would want to hear the news themselves or have a family member with them. There are several guidelines along with that. We want to ask them how much do they really want to know. We don't want to give them too much of an information overload in the first meeting itself, and be willing to, give them a private space if they, as they receive the news and as they grieve over it. And we can say, would you want to be alone? Should I come back after some more time? Sadly, in our busy practices, very often the news can be broken in the corridor. It may be broken to the relatives, family members. Very often, children of parents will come and say, please don't tell my mother, she won't be able to handle it. These are all things which happen every day. But we need to see what is the best to be done in that situation. Sometimes it's best not to tell the mother, but understanding the whole family circumstance and then breaking the news. Not to be in a hurry. I think that would be the most important thing, and be willing to give time, is what I would say when we break the news to the patient.
Thank you so much, sir, for this kind explanation on how to break news and how to break the diagnosis at first hand to the patient as well as the relatives. Coming to the pulmonologist, there are different ways of ventilator support that are available. There are different options that a patient can choose. So how important is it to educate the patient and educate the relatives on what are the ventilatory needs and what are the options that are available?
Yeah, so when it comes to supporting the breathing, there are two different aspects that we have to consider. One is the breathing muscle support, which is offered by a ventilator. And the second is the airway clearance, which is equally important because these patients are at risk of aspiration. Even if they've been fed via a tube, they might still be aspirating their own saliva. So the airway clearance is usually with the help of chest physiotherapy and various devices. And in advanced patients now, advanced MND patients, there is an option of another device called as cough assist, which helps them to cough out their secretions. So that is about the airway clearance. It is mostly delivered by the trained physiotherapist. When it comes to ventilation, now there are two types of ventilation. One is a non-invasive ventilation, which is delivered in the form of a mask, which is strapped over to the face and it is connected to a ventilator. The benefit of that is obviously you can take it off and you can put it back on whenever you like. And the other option, which is more invasive, is to do a tracheostomy and deliver the ventilator via there. The world is moving more and more towards non-invasive ventilator, where it has evolved a great deal over the last so many years, where there are much better devices in terms of the ventilatory devices, and the most important thing is much better interfaces. So when I talk about interfaces, that means the mask. And there are variety of masks that caters to variety of patients with neuromuscular diseases, especially motor neuron diseases. So that has to be, and this is not something that I'm going to deliver only in the hospital. It will eventually be the caregiver who will be doing it. And there are a lot of considerations that have to be taken into account when I'm handing over that ventilator and the mask to the patient and the caregiver to carry on at home. And all of that is usually done when we set up the patient on a ventilatory support. But this is one aspect of MND care which is known to improve the quality of life and the survival as well. So, and as I said, there are less and less patients from motor neuron disease who are going for invasive ventilator and more for non-invasive ventilator.
Thank you so much, sir, for explaining this very beautifully. Let's go on to the next panelist, that is Dr. Suvarna Ganbir, madam. Ma'am, patients have to be transferred from the bed to the wheelchair by the caregivers. What are some practical tips that you as a physiotherapist provide to caregivers to assist with safe mobility?
Yeah, the first and foremost thing that the caregiver needs to be trained is using some kind of assistive devices for these bed mobility or transfers from one place to another. But most important than that is letting the patient try to do the activities on his own. That is what needs to be informed to the caregivers, that they should not let the patient be dependent on them for every small activity. So the caregivers needs to give some time for the patient to do the activity on their own. Maybe the patient will do it at little at ease, or maybe with more difficulty, or they might take more time to complete the task. But the caregiver should give that much time to the patient and let the patient be as independent as possible uh, till whatever he can do. So that is one thing that the caregiver needs to take care. Second thing that the caregiver is requested to do is whatever the exercises the therapist has told. Probably therapist will do the exercises once in a day, but the caregiver is expected to perform some kind of exercises, some gentle exercises at the remaining time of the day, so that the joints are mobile as much as possible and the person is able to do their functional activities maximally. So these are the few things that the caregivers can be given tips about.
Thank you so much, ma'am. And we have Dr. Navita Purohit with us, who's a palliative care. And I'd like to ask you a question, ma'am. How does palliative care support patients with ALS? Does it happen right at the diagnosis or only during advanced stages, ma'am? Can you please lighten us on these things, please?
Thank you so much, and a very good afternoon to everyone. Yes, so we have this thing that palliative care means uh, this is the last stage, and then palliative care means end of life. So this has to be taken away from this. We, even the medical fraternity, when we talk to them, palliative care means end of life, means now nothing. You can go for palliative care. Palliative care has to be incorporated right from the diagnosis of the disease, where we know the life is limited. Like if you're talking of MND, so at least though we can start the talking to the patient and the relative, because it is not about not only the patient but it is also about the relative, because it's a long term disease and there has to be a caregiver burnout when they, right from the diagnosis, if we are there, if the palliative care physician is there. There are two types of mm, palliative care physician, like specialist palliative care or primary palliative care. So primary palliative care can be the ones who diagnose, like neurologist, or if they send the patient to a rehab physician, they can be the primary palliative care, or a specialist, those who are specialized in palliative care. So the specialist palliative care physician should be given the reference right from the beginning, for because the patient will have a there has to develop a rapport. If you send the patient during the terminal illness, then the rapport to the patient, it's a long way. Rapport to the patient and the relative, it takes a long time to develop. So the confidence as the team, it's the team. So right from the diagnosis, the palliative care physician should be taken into account that yes, we are there for you. We'll be there till the end, and to the family, not to the patient but to the family, the caregiver, so that the burden, because sometimes they don't have anyone to talk to, what they go through. We do send them to a counselor, but sometimes there are some things where they have so many things in their mind, and why me, why this is happening to my kid, or why this is happening to my relative. So there are these things, they can be taken care of, and they have to be educated that yes, in due course of time, we will be there with you as the primary physician, being a neurologist or or a rehab physician, or we can take over. So right from the diagnosis, I think, of any life limiting disease, for improving the quality of life of the patient and the caregiver, the palliative care physician services should be used. Because am I audible?
Yes, yes.
Yeah. Yes. Because that's what, if you see the course of illness, the WHO has given this guideline of the course of illness from the diagnosis or before the diagnosis. Right from the diagnosis, the palliative care physician should be there for this, and then the pathway or the map or the area for the primary physician, it reduces because the limitation to the treatment is there, and there's a paucity of the treatment of the disease, but it's the symptom management. So there they have to take over, or they have to run parallel with the primary physician. That's why it's very important, right from the diagnosis of the disease.
Geeta, there is a very,
Yes.
very important question which is lying in the question answer. And I think you asked Vinit to reply on this because genetic ALS is something, there are some new drugs which are available, and there are 5% of ALS which can be completely treated unless they have been diagnosed and treated. So could you kindly ask that particular question to Vinit? And Vinit, could you answer also that how many percentage of ALS are genetic and which are the treatable? Because it is very important that we should not forget those varieties which have now got treatment available out of all the others.
Thank you, sir. For genetic ALS, around 10% of ALS is known to be familial, which means another family member would have ALS in them. In the Indian cohort that has been published, basically that percentage is much lower. So we don't have as much of genetic ALS in India as in familial ALS, in the sense that of other family member, it's around, I think, 2% to around 3%. But at the same time, the role of doing genetic testing in ALS has expanded to not just in patients with family members who have ALS, but also in every patient of ALS now should get a genetic testing done. So what are the tests that you would order? We would order C9orf72. That is not done in the routine labs where we can, like you would send to a private commercial lab. They won't be able to do it. It's not available with them. So as of now, what we've been doing at our center is to send it to Delhi, where in IGIB they are doing this testing. That is one. Second, is to do NGS or whole exome sequencing on the patients with ALS. Now, why do we do that? Like sir was saying, SOD1 mutation ALS. SOD1 is the oldest mutation that was found in patients with ALS many years ago, many decades ago. That has got a molecule called tofersen, which is an antisense oligonucleotide, against which there is Dr. Pamela Shaw from Sheffield University. They were able to make this antisense oligonucleotide, and they have shown the benefit for patients by reducing the levels of SOD1 mutation in these patients. Also now, people are even looking at monoclonal antibodies against SOD1 mutation. So a lot of treatments that are coming up are targeted to the specific genetic problems that the patients are having. Beyond this, there is also FUS. FUS also has got a large registry running right now I think, out of Italy, where they are doing, Jackie Surson was one drug. I mean, I won't go into the details, but essentially to say that, there are a very targeted therapy in ALS, because ALS is now becoming more and more precision driven. It's not a blanket drug that will come for all ALS patients, but we'll have to drill down to the, transcriptomics, which is now the word, with genomics, proteomics, metabolomics, and characterizing what exactly is the problem in each patient and then targeting that. So yes, genetics is very, very central to patients with ALS.
Thank you, Jason.
Thank you, sir. Yes, sir. Can we go to the next question, next panelist, please? Dr. Srinitya, how do you work with caregivers to prevent burnout and maintain patient engagement at the same time?
Yeah. So education and training for the caregivers is very important. So how do we do that is through the form of groups. We conduct support group for the caregivers to make them understand like what exactly is the disease process, how they'll have to cope up with the patient. And sometimes what happens, caregivers in the initial phases, they tend to do everything for the patient in that enthusiastic situation, thinking that they're helping them, the patients a lot. But then we calm them down, we make them understand being independent by the patient is very important, so that in the initial stages the patients learn how to be self-made, that how whatever is possible for them, whatever is available within their limits, how much adaptations they can use, and they can be independent. So we help the caregivers understand that part of the activity, so that the patient will not completely depend on caregivers is one thing. And we also give them a lot of relaxation techniques through groups, which we conduct. For example, there is something called New Zealand therapy, where we make them understand there are certain relaxation techniques for caregivers alone also, and they can vent out whatever they face with our other caregivers, so they get a solution instead of we telling them how the other person handled the same situation. So that's how the caregiver burnt out situations is being helpful for the the caregivers to understand the problems better, and how they have to take up the uh, disease process, how they have to work with the patients to make them independent in their activities of daily living, or in their in terms of adaptations at home when they are alone, what are the control units they can give. All these are made in the group settings.
Thank you so much, ma'am, for that discussion and that points on how we can reduce the caregiver burnout. Coming to the next panelist, that is Dr. Preeti Shetty. Madam, what are the alternate ways to communicate when speech becomes difficult to comprehend in care?
Okay. If you see, communication is not just about talking, it's about how you're being heard, how you're being understood, and how you're emotionally connected. So there are multiple ways that you can look at. So there are something like low-tech AACs, that is alternative augmentative communication options that are there, which may be a simple paper and pen, alphabet boards, yes or no cards, or gesture systems that are there. There are mid-tech AACs which generate speech, and there are apps, and there are something like text-to-speech softwares, or you can use the phone or tablets that is there. And you also can customize those buttons, and you can keep common phrases, or personalized vocabulary can be programmed. So if you look at high-tech AAC, you have eye tracking devices, you have switch scanning or head movement control, where you can allow people to speak, type, or interact with one another. Even these systems can help to have a continued professional or family roles using this digital communication. So we match these tools based on the needs, preference, and the stage. If you look at early and mid stage, you can use the low tech AACs. If it is middle stage of ALS, you can use the mid-tech AACs. And if you see the advanced stages, you may need the high-tech AACs for communication.
Thank you so much, ma'am. Thank you so much, ma'am. Coming to our next panelist, Mr. Lukesh. Sir, what should families keep in mind when choosing or adjusting orthotic aids in patients with ALS?
Yeah. It's very important question. So as we understand that it's a progressive disease, and uh, the some other changes are required periodically in the orthosis to be changed. So the regular follow-up is needed, and with in that follow-up, we have to see whether the orthosis, the goal setting, we have set the goal for the particular orthosis, is it working functionally or not? Do we need to change something? So we have to assess them thoroughly again, and then uh, do little bit changes, and can be given again back to the patient who is coming back to us. In family perspective, they have to observe them very carefully. If they are getting hurt anywhere, they are getting pressure sores or something like that, so they have to come and visit and get a follow up, and with that follow up we can do certain changes in that particular orthosis. So both the things are very important in safety perspective, and family intervention is also important.
So now coming to Ms. Aswinder Kaur, who's a social worker, what message would you like to give a family who has just received an ALS diagnosis for the near and dear one?
First of all,
Madam, your
yeah. First of all, we advise them. Whenever a new person comes to us saying that we want to join the group and all, so we first ask them, understand the whole symptoms, because we have a kind of pattern which we could see that ALS is different for different kind of person. And also we can categorize the different kind of ALS, seeing what we have seen in 700 plus patients. So if there is some kind of signal which we see, then we ask them to get the second opinion and the third opinion as well, and then ask them to get the genetic testing done, because there could be a pattern found, if even if we are not considering a risk in the genetic. But yes, with the pattern we can think of, we are hopeful that something in the future can be found if those genes are not been identified. And then we ask them to keep a positive environment at home, be always connected with the support group, talk to the people who have already traversed their journey, they visit the families, and we have also created a state level chapters also, so that people get together, do meetups, and then understand. And because it's very, I think, comforting when a person understand the other person, what trauma, what emotional issues they are going through. So we also ask them to actually say to their loved ones always that we are there always, and also give uh, plan some get-togethers or celebration, and make them involved in whatever way they were doing it earlier also. Because we have many patients on ventilator in our group who are still going through doing their business, they are doing their job completely through eye tracker. So we have a lot of solutions for the higher lift when person is paralyzed, and lot of kind of key points which, as a patient support group, which we can offer, we share them all as in when somebody is diagnosed. We also created a kind of tool repository, a ready reckoner, and where one can know what needs to be done at which stage. For example, CPAP should not be used, plain oxygen should not be used. Even if somebody say lung function test is not there, is not in the limit to start the BiPAP. But yes, BiPAP, early BiPAP, and we tell them what are the signals to start arranging the BiPAP and avoid all kind of emergencies. So these are some practical experience which, as a part of the support group, we transfer them to these diagnostic people, the people who are the family who are diagnosed, and give them comfort that there is a life, and it's a beautiful life. do not worry about the quantity, but we can be at the right quality of life as much as possible. And that we can do that together.
Thank you so much, madam. This has been a really eye-opener from a patient-related point of view and from a social worker who has been dealing with patients day in and day out. Thank you, ma'am. One last question before we end this panel discussion and sum it up today. Navita, madam, what are some myths that you face in day-to-day life about palliative care that you would like to clarify for the families of patients with MND?
Yeah, this is a very important question, Hitav. As I told in the first, when I was answering the first question also, that the first and foremost myth is palliative care means end of life. Doesn't mean that, because it's a course of disease or the illness. Palliative care, when you are referred to a palliative care, even in the medical fraternity, I would like to say that they refer, okay, it's the end of life now, it's a palliation. Palliation doesn't mean that. Palliation means that the treatment for the disease is limited, now it is stopped. We are doesn't mean that it is the end of life. So palliative care and end of life care are two different things. Palliative care, when we start palliative care, doesn't mean, or the palliative medicine doesn't mean that this is the end, and the patient is going to die. That's the first and foremost myth. And the references to the palliative care physician should be early in course of, I know during the diagnosis, when I was in the last WFNR, and when I told that the palliative care reference should be at the diagnosis, everyone was laughing at that. But no, I would say that yes, this is why, because it is a long term relationship, and there is needs to be a rapport between the patient and the caregiver, as Miss Kaur was saying, that the burnout, and that is what, because palliation means the symptom management, so medical symptom management, then emotional and uh, 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 psychological support to the patient and the family. So, and doesn't end with the patient's death, but it is the bereavement also. So that is how we finish off with each and every patient, whether it is ALS or onco palliative or neuropalliative. So first and foremost myth, this is not one and the same thing. And this is for improving the quality of life. Doesn't mean okay khatam ab to, now ab kuch nahi hai. But yes, there is the life, whatever the life is left with you, there can, the symptoms can be managed, as we are talking about as a team. This is also a team, and this is a part and parcel. It's just the course of illness. So it's not over. We are there for you. This is always, we always keep on telling. The first thing which I go and when I go and talk to the patient, they are so scared. But when I speak to them, we are there with you till the end, and we don't know when the end is. They are so much. They start talking about the disease and how to go about it. And then also, it's not that the palliative care is can be done only in the hospitals in US, and there are so many different, if you're talking globally, it is not, the India has different ethical issues. There are some, there the family system is very good in few parts of the world, and whereas vis-a-vis in Western countries where a person lives alone, and then comes the name of hospice. So this is where we can divide, we can talk to them when we should start the end of life care, and also where should the patient, we should also talk about advanced directives. Living wills is very nowadays is, we can give living wills. From the last few decades, it has been, the Supreme Court has told that it is legal, and in India also. But in advanced directives in the Western countries, how I want to die, you can, you we have to tell them. It is not the patient will come and ask us, because they don't know. We can tell them, and that is why the rapport with the patient and the relative is very important. So once then the cognitively they are fit, we can tell them about, talk to them, that yes, this is the advance, you can discuss about it, you can talk to your family, yourself, how do you want to die and where do you want to die. And lastly, the bereavement. I think so. I have taken care of not only the myth, but how do we go about it?
Thank you so much, Navita ma'am. And we are well in time. And so I would just like to sum up this thing. And before that, I would
Wait,
request.
there are a couple of points which are, I would want some of the panelists to be, because I think they're very important point. I could read a couple of questions. So Dr. Sumit Singhania, the question to you is very brief, is when you think a patient should understand that there is a need of respiratory support. So what they should check and when they should immediately get attended that yes, now is the time that they should need the support.
So as I mentioned earlier, that we tend to follow up our MND patient right from the beginning, even when they don't have respiratory symptoms. The general dictum is that if their forced vital capacity is more than 60%, it is very unlikely that they will have a reasonable respiratory muscle weakness that will require BiPAP support. And when their vital capacity is less than 40%, it's almost invariable that most of these patients will require respiratory support because of muscle weakness.
What I mean, Dr. Sumit, is this is a degenerative disease. Patient is not going because doctors are not offering anything.
Yes.
So they will not come every month or every 2 months. They probably will come once in 3 months, once in 6 months. I want you to give them a tip like single breath count, what we look at in myasthenia, something like that, that you should check this. If you find that you are finding this difficulty, you should be alarmed and go immediately for further checkup.
Yeah, so like I mentioned in my first answer, that they should be looking for any early morning headaches, daytime excessive sleepiness. The respiratory muscle weakness goes hand in hand with swallow and speech. So if there are any alteration in swallow and speech, that should also alert them for the need of BiPAP. And uh, again, as you mentioned, not being able to complete a sentence in single breath, when their breathing pattern has become shallower, those are the times when there is a definite need. Especially also, people get their blood gas analysis done and their carbon dioxide level is normal, does not mean that they do not require BiPAP. So even if it is upper limit of normal, they are almost there. And in fact, we don't even wait till then. In borderline cases, when the patient does suggest of any symptoms, we do their early diagnosis by doing an overnight sleep study or mouth pressures. And if I can see any episodes of hypoventilation during the sleep, that is enough of a evidence to start them on a BiPAP therapy.
Okay.
Because if they manifest after infection.
Your point is very well taken. I think by the time the early symptom is early morning headache, as you pointed out, and the sleep disturbance. I think once they are there, person should get alarm and get in further, see the doctor to get investigation. Lucas, I have a question for you.
Sorry?
When do you think, because these patients get fatigue very early, when you think that they should not hesitate to use the assistive devices, and particularly I'm talking about the wheelchair?
Not hesitate to use the assistive devices. Okay, sir. So, sir, when the stage arises, like they are developing their contracture and now they are almost not able to do the mobility with a lower extremity and not functional as such. So they should get trained with the use of wheelchair mobility devices, mobility aids. Before that, they can use certain mobility aids like supportive devices, which are helpful them in their safety, like preventing the risk of fall and all. So there are devices like AFOs also can be modified in such a way that they can prevent the.
I'm particularly interested in wheelchair because this all you have already told. So what you have discussed, when you think that wheelchair they should use early or late, that's what I want to know.
Okay, so in late circumstances, they should go for wheelchair. Wheelchair should be well cushioned, well padded, and regularly checkup should be done for the pressure sensitive areas, like if there is any sore or something like that.
Perfect. I have one question, Suvarna. See, as a neurologist, many of us just go and do the physiotherapy. And these are the patient, they are progressively going down. Their energy is so low. Sometimes they are not even able to walk. And we keep on telling them do the physiotherapy. How do you modify and how do you suggest them that how do they do the regular? Because therapy is important to keep activated the muscles and the nerve. But at the same time, they should not fatigue. So what are the guidelines you want to give in few lines that these are the things which they should follow when they are tired or something?
The most important thing is that the therapist should not give vigorous physiotherapy, because this is a general norm that, patient has come to me, so the patient has to improve. That is what the therapist feel and believe. So the important thing is that the therapist should understand that whatever is the condition of the patient right now, the therapist should be able to at least maintain that particular condition by giving simple stretching exercises or maybe simple general low intensity exercises. That is what is required. So with these low intensity exercises, the mobility will be maintained and the person will not get fatigued to a great extent and will be able to do the activities at a much, much more better pace and with more effectivity.
Thank you very much. I think it is very important point because we just say do the physiotherapy 3 times,
Yes.
4 times. Sometimes it may be more harmful than the benefit. Preeti, I have a question for you, and there was a question also. How do you diagnose early aspiration? Because when they have swallowing disturbance, sometimes they don't even realize. So when how to prevent that, and how you think that this is the time, because nobody likes to put the Ryle's tube or peg. So if initially stage also when the people can diagnose that yes, this could be an early aspiration or silent aspiration, and this would needed to be helped or either by therapy or by the tube. Preeti.
Thank you so much, sir. That's something which is very, very important. If you notice, the patients commonly they complain about they cough or they choke whenever they're eating. Okay, so it begins with the thin liquid that may be water. Okay, that may be occasional in nature, but as they develop or as they go by, they have serious complications that are there. The other thing that you'll have to notice is the weight loss, or it may be initially you were taking 15 minutes to eat the breakfast, now you're taking long meal times, or the food is getting stuck, or there are certain food textures which you are not liking it, or you're having a lot of difficulty in that. Example, if you're eating a porridge, it is easy to eat, but if you have something which is very crispy, it gets stuck in your throat, or you may find it difficult. So that's when you'll have to identify what are these signs, and you'll definitely have to consult. And a safe and structured method to assess this is there. And once you assess this, you'll be able to personalize the care. So you'll be able to look at what is the proper diet, or what is the levels that are there. There are international standardized levels to identify this nutritious food or the food that you take in every day. And you also have to ensure that they are getting enough amount of nutrition and also hydration. So that's when you'll have to look at how to guide and how to feed safely. But I think if you take good care about how to have inputs which are safe and effective, definitely with the professional help, and carry forward this at home by the caregivers, are going to prevent or is going to delay the aspiration pneumonia that's going to come. So once diagnosed,
Preeti,
again,
the
yes,
challenge is that not all states and all districts have the swallowing therapists available. So could
yes.
you have some protocols being available which can be put on the IFNR YouTube for people to understand that if they have these sort of problem, this is how they can take care by the assessment and swallowing. I think it is very, very important because swallowing therapists are very few across the country, and there are many places, diseases everywhere, but the therapists are not available everywhere. And I think you should work on, producing the protocols for early intervention to prevent aspiration pneumonia, to what are the therapies can be done, not only for ALS, but also for many other degenerative, neurodegenerative diseases. Lastly, I
Yes.
have one question, Vineet. I mean, when we diagnose MND, we say, okay, you got only life of, say, 2 years, 2.5 years. And this has been, I have been talking about this for last 40 years, ever since I've been practicing. Is it true now? can the better care and the availability of newer medicine, the lifestyle has changed? So can we always tell the patient that you got this many months to live? So what are your suggestions and how you see now? You are the young, I'm in the old school. I'm talking of 6 months to 2.5 year bulbar with generalized. Now, what are the exact thing? Because people should know that it is not that there is a timeline that you will go up to this.
Yeah. Thank you, sir, for that question. Yeah, I think, sir, it's very, very important that it's very hard to predict. There are predicting scores which have been there. There are scores which tells us what will be the rate at which this patient will progress. They have not come from Indian data. They have come from European data. So there's a limitation for using it. But essentially, the time from onset to the time for diagnosis tells us how slow the disease is progressing. I have a patient who had bulbar onset ALS, and she in 2019 till 2025, her ALS FRSR has dropped only from 44 to 43. I keep doubting myself whether this is ALS or something else, but it is ALS. I mean, we've really tested her so many times. But so it is not one timeline. That is very important. The other thing is the most significant thing that has made a change in their lives has been care in a multidisciplinary team. Use of NIV, yes, very clearly has helped their life being prolonged. Sadly, the disease modifying drugs have not been very effective. Riluzole, we know around 3 months at the most. Edaravone, some studies say benefit, some says doesn't benefit. I was very sad to see Relivrio go off the cards. You know, that was really heartbreaking to see that drug which came out so promisingly has gone out. But then there are so many drugs in trials. It's such an exciting space to be in. But like I said at the first, multidisciplinary care, that makes the world of difference. And multidisciplinary care in our country has been difficult because it is so scattered. Specialists are in different places. Patient has to move from one center to the other. In some centers, in our center, what we've been able to do, basically we admit the patient for daycare admission just for 8 hours. So it's very minimally built. They don't stay overnight, and in the morning the tests are done, and in the afternoon all the consultants who are part of the multidisciplinary come and see the patient. There's a standard structured protocol what everybody needs to see, and then we have our coordinator who then summarizes it and makes a discharge summary, and then we have an MDT meeting like this and we discuss the patients. It's a very fresh start. It's not like we've done a lot of patients, but we've taken from our Duchenne's multidisciplinary team and made a model for ALS as well.
Wonderful. I think this is something which we need to do, and that's something. I'm sorry, I have to ask a couple of questions because I felt that if I have this query, many of the people who are listening, they might also will have this query. So I might well clarify that from the expert. All of you who are here, it's very difficult to get all of you at one platform on any day. Etha, over to you. Sorry.
No, sir, it's your guidance and your experience that counts. And that is how we have been also learning in this journey where the IFNR and the neuro rehab succession of IAN has been bringing this to the common people and the common healthcare professionals to improve their awareness about these conditions during important days by their associations. So I would just like to sum up a few things that were discussed today. One is always multidisciplinary team, early intervention, early diagnosis. Take care of the caregiver because that's how the quality of life of your patient also improves. The family takes care of the patient. It's a cycle. So always seek help when it is needed. Refer always rather than keeping the patient to you, because another professional will see a patient in a different angle which will benefit the patient in some way or the other. And always stay positive, and there is hope somewhere or the other where there will be a drug which will come out and which will cure this incurable disease. Till then, sit tight and let's hope for the best. And I would like to thank everyone for spending their afternoon with us. And with this, by the permission of the chair, I would like to end this session here. Thank you so much.
Abhishek, you can few words and close it.
Just to add a couple of more points, I think The impairment-based approach concept, which we use in stroke and brain injury, should be incorporated in MND care also. One. Second, always utilize MDT care approach. That is very well documented. It helps beyond normal conventional protocols. Third, the therapy has to be goal-directed. Not do too much also is good sometimes in patient with MND. Fourth, look for early signs of dysphagia and respiratory involvement and when to plan for tube feeding or BiPAP requirement. Sixth, use of advanced directives as well as living wills is a big concept. Involve palliative care early, involve social support groups early, the quality of life is better. And always remember, as we have seen today, if you all can work together, the patient outcomes are better. So always utilize multidisciplinary team care involvement in the care of patients with any type of neurological disorders. Thank you very much.
Thank you. Thank you so much.
And see you again in some other sessions in future. Thank you, Vita, for doing a wonderful job. Thank you, Vineet. Thank you, Sumit.
Thank you.
Thank you.
Thank you, everybody.
Thank
Bye-bye.
you, everyone. Thank you.
Vita,
Thank
Thank you,
you.
sir. Thank you,
we
everyone.
missed
Thank
you
you
in
all.
the beginning. Thank you all.
Thank you. Thank you, everyone.